Perfect. Our event will start with opening remarks from Anissa Dwi Utami, the head of SID. This will be followed by a brief introduction to FHIR from our colleague, Elia, then short presentations from our collaborators. A panel discussion with 4 FHIR course alumni joined by our senior staff, Ms. Unidwi Setiawati, will be at the end. And then we will hold a really short, very brief Q&A session where attendees will be able to ask any questions you may have to our speakers. Without further ado, let me introduce you to Ms. Anissa Dwi Utami.
Okay, thank you, Tari, for the nice opening of this event. So good evening from Indonesia, everyone. Welcome to our webinar, A Future on FHIR, Revolutionary Team-Based Healthcare with Data Interoperability. So we are very pleased to have you all here today. I'm Anissa Dwi Utami, the head of Summit Institute for Development, as mentioned by Tari. It is an honor for me to speak on behalf of SID. So let me begin by giving you a warm welcome to this webinar. Before we get started, I would like to express my appreciation to our colleagues from the Digital Transformation Office of Ministry of Health, Republic of Indonesia, Family Health Directorate from Ministry of Health, the Ministry of National Development Planning or Bappenas, WHO Human Reproduction Program, HL7 ONES System, Oxford University, Faculty of Medicine, Universitas Indonesia, Indonesian Doctor Association, and all of our partners from provincial and district health offices. Thank you for all of your support and your attendance to this webinar. In today's webinar, we will have a short presentation from SID and our collaborators, followed by a panel discussion from our FHIR course alumni. The FHIR system or the Fast Healthcare Interoperability Resource System is an interoperability standard for the electronic exchange of healthcare information initiated by Health Level 7, who is here with us today. So it is not just about data integration, but a coordinated and continuous care through data interoperability. So the goal of today's webinar is to demystify and straighten any misconception about FHIR, as well as to introduce FHIR to non-developers. And hopefully, this webinar can be a first step towards the adaptation and implementation of FHIRs for the Indonesian health system. The webinar itself will be held continuously as a series to provide further updates on the project implementation. We hope this webinar will enable us to have a better understanding of interoperability of healthcare system. Today's meeting is also very important to bring up the collective spirit of success and synergize our steps together. With all the crucial expertise our partners have, we believe it will support the huge success to the adaptation and implementation of FHIR globally and in the country. Well, I don't want to take up much of your time, so I will hand it over to Ms. Tari, our today's Master of Ceremony, to introduce our speakers to all of you. And I would like to say once more on behalf of SID, welcome to this webinar. It is great to see so many of you here. Thank you.
Okay, thank you so much, Ms. Anissa, for opening remarks. As you mentioned, our topic today will be to introduce FHIR and explain its importance. We would like to expand on its potential values to our current health system here in Indonesia as a way to improve healthcare through data interoperability. Let's now move on to our first speaker, Elia, a fellow SID staff member. Elia, the floor is yours.
Okay, thank you so much, Tari, for the nice introduction. I'm going to share my screen. Wait a minute. Could you see my screen? Okay. Okay. So hello, everyone. Good morning, good afternoon, and good evening, everyone. In today's session, it's very exciting for us to have the discussion about the future empire revolutionary team-based healthcare with data interoperability. So for the presentation itself, I'm going to start with walking you through the current situation and challenges of healthcare system in Indonesia. and then going for the needs for broader aspects in interoperability using standardized concept utilizing FHIR. And the most important point is the next step, the future on FHIR in Indonesia. So let's go through to the current situation and the challenges of maternal care in Indonesia. Here, we can see that the pregnant woman should go to the multiple places, multiple providers to get the complete care that she needs. What makes the situation worse also is once they came to the puskesmas or public health center, the result of the routine care cannot be integrated on the other facilities, even though the same facilities, but different providers. And this is absolutely not an ideal situation for a mother. We also realize that the health workers collect a lot of the same information, but it is not standardized by the name or data structure or how the data exchange system works. So the data is not exchangeable between these workers here. We found that 40% of information is duplicated, but not interoperable. This is very inefficient and lessens the quality of the care. So what is the ideal concept of the care and the system that we need? The model of the maternal care is supposed to be a client-centered care. And this is what we are trying to do using the OpenSRP, to have a coordinated team of workers that place the client in the center of the care. For example, the nutritionist and midwife can have integrated nutritional status data, so there won't be any duplication or misunderstanding about the data. And what does the impact if the data can be exchanged and the network system happen? The shared interoperable data could enable complete health records to be compiled across the care plan. For example, you can see on the left, we see a midwife may have a care plan for pregnancy and data she is supposed to record. In practice, however, the actual data is incomplete and fragmented. But if we can create a team approach to coordinated care from multiple workers, the compiled data can be more complete, so the pregnant women can receive the best care that they need. Also, specifically for maternal and child care, this is also very interesting, that midwife alone can increase the ANC, reduce low birth weight and maternal anemia, which are good. But if the care is given integrated together with midwife, nutritionist, and vaccinator, the PNC and vaccination can be enhanced. In addition to that, as you can see here also that the OpenSRP use among multi-cadres enhance ANC, PNC, and reduce the death. This shows that team-based care using network system could really improve the public health practice here. So why is this still not being implemented in Indonesia? Let's see further what is the current data situation in Indonesia. So here is the simple example of what is currently happened. As you can see here, the variable name of the patient identity is different across systems. It also is defined differently. Take the name as an example. There is no definition what name that the system has. Is it given name and family name, or the given name only, or the order should be the family name first followed by the given name, or the other way around? There is no standard applied for the terminology. And the definition of the patient identity itself also different. In one system, the system 3, for example, the patient identity should include blood type, but the other system does not include that. So how can it be exchanged? The issue actually is not ended there. How can the data can be communicated between one system to another system if it does not have the same standard also? So we have to address these 3 challenges to make the system interoperable, meaning can communicate to each other. And actually, there has been a standard that addressed this package of challenges, and it is called FHIR, stands for Fast Healthcare Interoperability Resources. So what FHIR does is standardizing the exchange of healthcare information that uses resource as the building blocks. Okay, let's go back to the previous slide for a bit. There is this column of the patient identity with the name, for example, and then the gender, the birth date, and this column represents the resource. And FHIR has resource defined in very well documentation, as you can see there. Here, I have a patient resource here as an example with the elements that I highlighted inside the red box. So we know from this what information should be included in the patient resource and how it is defined in the system. And this is also important point, I think. If it's readable by human, but not computable, meaning that it cannot be processed on the system, it also won't be interoperable, which is FHIR actually address those 2 points, human readable and then computable. So let's dive in more on what a resource is. Here on the right side of the screen, there are the key parts of a resource. The example is the patient resource. It has identity and metadata, and then below that, there is the narrative or text section. This allows a human to safely view a resource. And then below that, there is an extension. This allows an implementer to add an element that is needed by their implementation, but is not included in the core dataset. Core dataset means the structure below that, the standard data content. And having extension will reduce complexity while supporting variety, where standard actually needs to have this ability. And then next, there is standard data content, core data set. This is the list of elements that appears in the specification and which all FHIR implementers need to understand. To be included in this data set, the rule of thumb is that 80% of systems currently support the property. By having this resource with the same understanding, the data can communicate between systems. So the data is not isolated in one system. You do not need a centralized data storage to have the data exchange across systems. Although you have different servers to store your data, it won't matter. To highlight more the point about FHIR, let me summarize again that FHIR actually is highly interoperable for any other software and device. So it's not about what application or devices should be used, but about the standard on how the application can communicate to each other. So FHIR is not a software system, is not a specific mobile app or device, is not a specialized digital hardware, and not restricted to a centralized server. It does not need a one big server in a one place to store the data. So actually it's able to be implemented in the different servers everywhere here in Indonesia with high level of security. And to make this implemented, what does need to be done then here in Indonesia? As the first step to implement this, FHIR needs to be adjusted based on what standard applied in the healthcare system in Indonesia. So everyone who wants to create new software, for example, or anything to support the health information system will have the same standard, the same guidance on how to make it interoperable with other systems that other parties have created. And creating working group together could be really helpful to accelerate this process of creating the FHIR national guidance, deciding what resource needs to be contextualized in Indonesia, what data that is mandatory here in Indonesia, and other process needed. So working group is really important. And in order to make it happen, actually, SID has been in collaboration with HL7, that currently Diogo from HL7 has joined us today. Very exciting to have you here. And the mandate is for SID and HL7 to develop a FHIR curriculum for non-developers that will be used globally. HL7, in collaboration with SID, provided 220 scholarships for Indonesian to complete the FHIR fundamental course in August 2021, and 18 of them received the certificate. And the good news is HL7 also will provide 20 more scholarships to attend the FHIR fundamentals course in October 2021. And the scholarship recipients will be selected on a competitive basis. So all participants here, you can really apply for the scholarship, and it will be really insightful for you to join the course because it will give you many insights on how to implement the FHIR, both for developers and non-developers. And for your information about the course, it's actually a learning by doing course. So you need to practice a lot there, and it comprises of 4 modules there that you can see there. And it's really insightful for you if you can join, and we can start to understand more about the FHIR. And to sum up my presentation, I would emphasize that standardized digital health tools can facilitate interoperability, extensibility, and scalability. This enables sustainable enhancements of human resources, knowledge, and action for better care delivery. And to close my presentation, actually, there is one quote that I really like that actually, as SID also has this principle in our work. Alone, we can do so little. Together, we can do so much. So let's make this happen for better healthcare in Indonesia, not on behalf of one party or the other party, but on behalf of Indonesian people itself. So I think that's all from my presentation. I will hand it over again to Mentari. Thank you so much.
Thank you, Elia, for the very, very, very nice presentation on introduction on FHIR. Now, after knowing briefly what FHIR is, we have Bapak Setiaji from the Digital Transformation Office of the Ministry of Health of Indonesia, who is here to talk about Indonesian government's interests in FHIR itself and how it can be implemented here at home in Indonesia. Before his presentation, though, I'd like to refer you to a Google Docs link that we have in the group chat for a live translation of our webinar. And without further ado, Pak Setiaji, if you would so kindly start your presentation.
Okay, thank you, Mentari. First of all, I would like to thank you for this discussion here. I think this is very important thing for us, especially for the Ministry of Healthcare, to improve the let me share the presentation. Okay, maybe we because the time is very short, I want to talk about how we manage the COVID-19. Actually, we have a lot of applications to use for the COVID-19 management. Not only about the system from the health facility and also some laboratory for COVID tests, and also how we record this result. And then after this, we trace using the other application, and then it's used also for the telemedicine or for the quarantine system. And then also using now, maybe you know about the Peduli Lindungi is some viral application now used for the screening and also for the tracing. And then we integrated all of the data into this. Actually, this system is not used some standards. So if we need to start to interoperability within the applications, we need some big effort to integrate this, because there is no standardized. And then even some reference for the facility like laboratory, puskesmas, hospital, and etc. So we need some extra time to interoperability within these applications. Maybe this is more clearly the picture of how we manage the COVID. Actually the sum of the system we share using the some API, but this is not standardized. So you can imagine if we connect this system to 1,000 of the facility of the like a hospital, laboratory, and also the puskesmas and etc. And then also within the others application like some platform for the telemedicine and etc. So if we have some standardized, it will be help us to integrate it within this, because as you know, we now some initiative to build like one personal health records. Maybe next year we will build this initiative. So I think we need the FHIRs to standardize some activity or some data exchange within its facility. For the sample like this, we need for order tests, so we can request some FHIR standards, and then for the mortality report, for the condition observation and etc. And then using some FHIR standard for the like a confirmed case using the FHIR, etc. And this is some idea how we use the FHIR, but for the decentralized. And then maybe for the centralized, maybe we can use like this, for the decentralized using the standardized for the SL7 or FHIRs for connecting into the or intra for its facility. Yeah, this is some idea how we need the FHIRs for our programs, interoperability within its facility, because we need to develop or we need to integrate it more application, more facility, and etc. Yeah, I think we need more discuss about this, how we can collaborate for the workshop. Actually, we have some workshop for that, and we need this initiative to be clearly how we can use the FHIRs. Maybe this idea is not correct. We need to finalize the setup of the topology of the FHIR itself. Yeah. So after we have some clearly of the topology, we can develop this on the next years. I think that's. Thank you.
Okay, thank you very much, Pak Setiaji. That was a very insightful presentation on how the implementation of FHIR and different health systems can improve our digital health system, especially in these environments during the pandemic, of course. And now, not only from the Ministry of Health, we also have in our company, Ibu Inti Wikanestri from the Ministry of National Development Planning, or Bappenas, who will talk about the importance of data interoperability towards one of the major issues in health, which is stunting. She will be presenting in Bahasa Indonesia, and we will be providing live translations over at our Google Doc. So please refer to that for English translations. Selamat malam, Ibu Inti Wikanestri. Terima kasih atas kehadirannya malam ini. Mungkin langsung kami persilahkan untuk memulai presentasinya. Terima kasih.
Ya. Terima kasih Ibu Tari, Bapak Ibu semua, selamat malam. Seperti yang diminta oleh panitia, kami akan menyampaikan mengenai interoperabilitas data kesehatan, terutama untuk upaya percepatan penurunan stunting di Indonesia. Seperti yang sudah disampaikan oleh pembicara sebelumnya, ini adalah bagian yang sangat penting dari sebuah kolaborasi data untuk contoh dalam percepatan penurunan stunting. Konsep stunting sudah kita ketahui bersama bahwa ini merupakan kolaborasi kerja bersama untuk penurunan stunting di Indonesia, merupakan sebuah permasalahan yang kompleks dengan intervensi yang dilakukan oleh berbagai pihak, sehingga perlu sangat diketahui bagaimana mengintegrasikan, menyatukan berbagai hal yang menjadi bagian dari peran masing-masing sektor, sehingga perlu dilakukan kriteria-kriteria tertentu seperti pendekatan tematik, holistik, integratif, dan spasial. Artinya sebuah kegiatan stunting ini harus dilakukan secara integrasi. Kemudian juga ini menyatukan program yang ada di pusat sampai ke daerah, melibatkan provinsi, kabupaten, kota, sampai dengan desa, unit terkecil dari sisi kelembagaan di pemerintah Indonesia. Kemudian juga ini melibatkan 25 kementerian lembaga, sehingga perlu diketahui bagaimana model nanti pemantauan yang harus dilakukan. Kemudian juga selain pemerintah, kita melibatkan berbagai sektor non-pemerintah. Artinya dukungan semua pihak benar-benar harus dilakukan kerja bersama, dan itu tidak mudah untuk melakukan pemantauannya. Bagaimana efektivitas kerja bersama ini bisa menurunkan stunting. Kemudian juga model dukungan pembiayaan, perlu kita lihat juga bagaimana efektivitas dukungan dari berbagai sumber pendanaan non-pemerintah dan pemerintah, kemudian juga model-model mekanisme anggaran yang didukung untuk penurunan stunting ini efektivitasnya seperti apa. Bagaimana kemudian interoperabilitas data ini diperlukan untuk mengetahui apakah memang program yang sudah dirancang ini benar-benar terdeliver dengan baik begitu sampai ke unit desa, karena di 2024 kita harus benar-benar mengevaluasi outcome yang diminta oleh Presiden untuk penurunan stunting menjadi 14%. Kemudian juga bagaimana dampak yang selama ini sudah kita lakukan, intervensi berbagai peran kementerian lembaga dalam penurunan stunting. 25 kementerian lembaga itu bagaimana irisan-irisan kegiatannya, kemudian juga apakah memang program kegiatan yang diberikan sampai ke unit desa ini benar-benar bisa optimal. Kemudian juga apakah dari sisi perencanaan di awal sudah sesuai dengan sasaran yang memang tepat begitu, dan juga apakah lokasi-lokasi yang dipilih itu juga merupakan lokasi yang mempunyai prevalensi stunting yang tinggi. Tantangannya adalah ketika kita melakukan data-data ini, bagaimana mulai dari input, proses, output, outcome, sampai dengan impact-nya gitu ya. Karena tahapan-tahapan dalam ranah perencanaan tentunya harus kita perhatikan betul bagaimana target-target yang sudah ditetapkan itu benar-benar berdampak nantinya pada penurunan stunting. Dari sisi isu sistem sendiri, kita perlu melihat betul bagaimana 25 kementerian lembaga yang bersatu dalam percepatan penurunan stunting ini, mulai dari ranah perencanaannya, kemudian bagaimana metode dan mekanisme penganggarannya, capaian-capaian outputnya seperti apa, apakah ini benar-benar merupakan sebuah sistem yang menyeluruh begitu untuk percepatan penurunan stunting. Kemudian juga apakah pelaksanaan percepatan penurunan stunting yang dilakukan oleh 25 kementerian lembaga itu kemudian didukung oleh penganggaran baik pemerintah maupun non-pemerintah benar-benar sudah terintegrasi menjadi sebuah satu kesatuan program. Ini juga perlu dilakukan evaluasi yang menyeluruh, karena selama ini laporan pelaksanaan percepatan penurunan stunting hanya melihat dari situasi yang ada, perkembangan yang ada, belum menganalisis secara tajam hasil-hasil dari capaian itu, apakah memang benar-benar sebuah efektivitas yang berlangsung begitu terhadap percepatan penurunan stunting. Kemudian dari isu programatik, efektivitas kegiatan dan kinerja program juga tadi disampaikan belum benar-benar melihat bagaimana sebuah kegiatan di satu kementerian lembaga benar-benar berdampak sangat tinggi terhadap percepatan penurunan stunting. Dari sisi spasial lokusnya, apakah daerah-daerah yang menjadi wilayah percepatan penurunan stunting itu benar-benar merupakan wilayah yang memang menjadi sasaran yang tepat terhadap program-program percepatan penurunan stunting. Juga belum adanya mekanisme feedback dari pemantauan yang belum menyeluruh itu terhadap bagaimana kemudian dari sisi perencanaan, mulai di perencanaan, penganggaran, kemudian juga realisasi anggarannya, keberhasilannya, itu belum dilihat secara bertahap begitu. Artinya ada sebuah sistem yang perlu dibangun terhadap evaluasi keberhasilan percepatan penurunan stunting. Sehingga penting sekali interoperabilitas untuk penurunan stunting ini dilakukan, yaitu untuk melihat peran dari masing-masing kementerian lembaga yang terlibat. 25 kementerian lembaga itu punya indikator masing-masing, baik intermediate outcome, output-nya yang seharusnya saling mempengaruhi. Nah, ini kita belum lihat bagaimana efektivitas dari kebersinggungan antar indikator tersebut terhadap intervensi-intervensi yang dilakukan di penurunan stunting. Kemudian juga bagaimana kontribusi setiap kegiatan di instansi itu terhadap percepatan penurunan stunting. Diperlukan memang sangat tajam analisis untuk melihat keberhasilan dari peran masing-masing kementerian lembaga terhadap
Ibu Inti.
Itu bagaimana menyatukan sistem informasi tersebut ke dalam sebuah sistem yang besar begitu, terutama untuk percepatan penurunan stunting. Kemudian juga kita perlu memastikan bahwa target intervensi stunting di 1000 hari pertama kehidupan itu merupakan sasaran yang tepat untuk benar-benar mendapatkan intervensi. Interoperabilitas ini merupakan sebuah penerjemahan dari integrasi data, sehingga memang evaluasi pelaksanaan dari percepatan penurunan stunting itu benar-benar dapat disatukan gitu untuk melihat capaian-capaian dari percepatan penurunan stunting, dan dari itulah kemudian integrasi data itu kita bisa lihat untuk pemanfaatan, perbaikan, dan rekomendasi ke depan. Peluang yang dapat dilakukan dalam hal ini adalah kita sudah punya Peraturan Presiden nomor 39 tahun 2019 tentang Satu Data Indonesia, sehingga ini menjadi peluang yang sangat baik untuk kita menyatukan sistem pendataan untuk percepatan penurunan stunting, bagaimana menata kelola data-data baik di tingkat pusat sampai daerah, mulai dari perencanaan, pelaksanaan, evaluasi, dan pengendaliannya, sehingga benar-benar efektivitas penurunan stunting yang sudah dilakukan secara terintegrasi ini bisa dilihat. Kemudian juga bagaimana kriteria-kriteria pendataan yang perlu dilakukan sehingga terdapat pemahaman keperluan data-data yang diperlukan dalam capaian percepatan penurunan stunting. Selain itu, sekarang kita sudah punya Peraturan Presiden nomor 72 tahun 2021 tentang percepatan penurunan stunting, yang di dalamnya kita sudah mengetahui betul peran dari masing-masing kementerian lembaga terhadap percepatan penurunan stunting, di mana Bappenas dalam hal ini menjadi lembaga yang berperan dalam melakukan pendampingan terhadap pendataan percepatan penurunan stunting, sehingga pemantauan dan evaluasi harus didukung betul dengan satu data terintegrasi mulai dari pusat hingga daerah. Kemudian juga pengembangan sistem data dan informasi terpadu ini sangat diperlukan dalam percepatan penurunan stunting, sehingga di akhir 2024 prevalensi stunting 14% itu benar-benar nyata terlihat dari integrasi data ini. Terima kasih Bu Tari atas waktu dan kesempatannya. Saya selesaikan sampai di sini pemaparan saya. Kami kembalikan ke Bu Tari.
Oke, terima kasih banyak Ibu Inti atas presentasinya tentang stunting ya. Thank you very much for speaking about the issue of stunting and how having data interoperability can really improve care, although there are still many issues right now. Now, next we have Carl, WHO advisor and collaborator on digital health and FHIR, who will talk about WHO's role in the FHIR system. Hello, Carl. Thanks for joining us. I'm handing it over to you now. Carl, you're still on mute.
Oh, can you hear me now? Are you able to hear me? Okay,
Yes.
great. Thank you very much for the opportunity to discuss WHO's efforts in supporting FHIR. As soon as hopefully you're able to see my screen.
Yes.
Okay, great. So I do want to talk a little bit at what WHO role is here and what they're looking at. One of the important things that WHO does is develop guidelines using global evidence-based for the health systems and improving of clinical care. Those guidelines are adopted into national systems and are used as a basis for defining procedures, protocols, data sets, and indicators. And as those are adopted in country, evidence is collected and informed back to WHO for updating of those guidelines. With those guidelines, we need to actually get them into digital systems through implementation and technology partners, where they read those guidelines and translate them into digital solutions for the health workforce and for the health service users. The one problem that we've noticed over the years is that translation step from the guidelines to the technology partners is often problematic. It can be slow or resource intensive. It's difficult to update, particularly with data systems that are on the ground and without a lot of funding or resources to update those systems. And there's issues with interoperability and data standards. So what the WHO has done is to develop a process for moving these care guidelines into the digital space. But currently, sort of a lot of the guidelines that we see that are digital are perhaps inaccurate or it's hard to test to ensure their accuracy, not fully trusted. It's inefficient and cost-wise to update and refine digital health systems based on those guidelines. They aren't transparent or scalable, or not interoperable. So one of the ways that we're trying to address these challenges is through the SMART guidelines. So SMART guidelines is an approach to moving those WHO guidelines, the narrative content, into a digital form to increase the adaptation and accelerate the digital health transformation of WHO member states. So a few things about what guidelines are and what they are not. I think similar to some of the comments earlier around FHIR, SMART guidelines are not digital applications. They're not bound to a specific product or solution. It's not a data solution. It's not a way to push one particular software product onto a ministry. And it's not only about health information exchange. What it is an approach to create more living guidelines that we can have quicker feedback cycles between WHO, member states, and implementing partners of these digital health solutions. And it's a hybrid between the clinical and data recommendations for information management. Does include the data standards and consistent ways of calculating indicators and metrics. And it's an approach that we can use at a global scale to try to harmonize the way that clinical care is provided digitally. To make this translation into the digital, we go through 5 levels of knowledge representation. So on the left-hand side, we see L1, the narrative representation that represents the way that WHO has typically released guidelines. These are very text-heavy and don't necessarily provide a lot of the detail that the implementers of digital health solutions are needing. The next step is to get there is to look at the L2, the operational level, where we take the narrative guidance and develop more human readable, but components that are really designed to get into the information systems. That includes workflow diagrams, data dictionaries, user personas, things that a business analyst would typically develop before developing a software solution. The third level, the L3, is the machine readable, and this is where we see FHIR come into play. So this is taking the outputs of L2 from the business analyst and converting them into the FHIR standards, determining the correct terminologies and codings to use, how to express decision support services or indicator calculations in standardized ways. Once we have that L3 machine readable content, which is independent of any particular software platform, we can move this into executable software and then deploy it in a country and have a process to streamline the adoption of the narrative guidance to the L4 executable level. To give you a sense of one quick example of what this looks like, is the WHO's recommendations for antenatal care. In here at the L1 level and in the narrative document, you would see specific recommendations that are given in a narrative text form. Moving into the L2 level, you would have the workflow decision logic expressed up in the upper right hand and the workflow diagram, as well as a decision logic table that really says for each of the data elements, what are the conditions that are required to provide the best quality clinical care. Moving into the machine readable, which is where we see FHIR on the right-hand side, we developed FHIR implementation guides that say exactly how to use the specific FHIR resources and data models. So you'll see from FHIR, it's quite a large space and lets us do a lot, but how to use it is specified in these implementation guides and with the narrative guidance. On the lower right-hand side, you see a standardized way of representing clinical decision support using something called the clinical query language. This is also used for indicator calculation. Again, this is a standard, it's independent of any particular software system and is implemented in a number of open source tools. And you can see on the left-hand side where we draw upon the previous L1 and L2 artifacts to generate the L3 FHIR implementation guide. And finally, we get into the executable, which is the software codes. And there's a number of software libraries and tools that already adopt FHIR and can really accelerate the software development using the artifacts in L3. And I'll just close by saying that the WHO is rapidly expanding its use and recommendations of FHIR, not just for ANC as we've seen, but for a variety of health verticals, including HIV, COVID, STIs, and the list continues to grow. So this is a trend that is growing, and we're glad that you're considering FHIR and looking forward to working with you all together on this. Thank you.
Thank you very, very much, Carl, for speaking on behalf of our partners over at WHO. That was a very informative presentation on the role of WHO in FHIR and myth-busting misconceptions, I like that word, about smart guidelines. And that's pretty much what our webinar is here for today. It's Mythbusters Night for us. And now on to our dearest friends over at Health Level 7 International, the ones whose work is of our main focus for the day. I'd like to welcome Diego. Hi, Diego. Thanks for being here. So
hi, thank you.
We'll be talking about HL7, about FHIR and its success in various countries. Is that correct?
Yes, that's correct. I will share my screen now.
Floor is yours.
Let me see.
No, not yet.
Not yet.
Mm-hmm.
We'll get there. I think we are here. We are sharing.
Yes, perfect.
Can you see it? Perfect.
Yeah.
Thank you. That's my introduction. I will not go through it, so you have to read it fast. I will go through it. Mainly, I'm one of the educators in HL7 and trying to create knowledge for everyone in the world that needs to know HL7 and especially FHIR right now. So about HL7, it's a nonprofit. I will not read everything, but you can read it. In more than 50 countries and 1,600 members. And our vision is the right health information for the right person when they need it. And our mission through the years, I'm with HL7 since 1999, 21 years now. It's to provide standards for global health data interoperability and to make them available and to make people know how to use them. And this is what we are doing. So about FHIR is our latest generation standards. It's the newest, but it has 10 years. So that's for you to give you a hint on how fast healthcare moves. So as an industry, we are really slow. And FHIR is a data exchange standard, as you have discussed. So it defines how we exchange information between one or more systems, but it's also a vibrant community. So in the community, we define, discuss, and educate on how to use the standards. And HS7 is FHIR's home, is where we develop the standard. We develop each new version of the standard, and then we maintain and discuss what's next, what can be fixed, etc. And this is our current global presence, where HS7 has affiliates. And the mission of the affiliate is just the same as HS7, but in its own country, carrying the needs and the consensus of the local community and making FHIR usable, or the HS7 standards in the past too, for its own needs. And this is how everything began. So it began from outside to the center. So you begin by creating a new community or gathering existing communities of practice or whatever you are working on in healthcare. And then usually it begins bottom up with some implementers working, and then some developers also working on these implementations and the needs for standards. And when they get together, they go to more to the center of our work, where we create local implementations for something we call round specific, for a specific domain and country, and then for specific domains inside of the country in levels 2 and 3. And maybe this work will end up with you collaborating with the global definition of the standards. You have needs that are not taken into account in the global definition of standards. You can collaborate to make those needs being heard and being taken into account. So the more in the center you are, the more near global definitions you are. This is the journey of usually of our communities. And speaking of the number 2, the realm specific core IG developers or base IG developers, why are we using FHIR? This is a word that is not an English word. It's something I invented some years ago. It's called infrastructure. So to exchange information, clinical information, you need the bottom half of this graph solved. You need to know who are the physicians, who are the practitioners, who are the organizations, and the identity of these organizations. The patient identity, whatever patient identity you have in your country, and whatever is your base data you need to exchange about patients, which consent the patient has given for the patient information, who can see the information and who cannot. The fact that the users can or cannot access a specific patient information and different areas of patient information is not the same in a nutritionist than a surgeon, or in emergency care than in a mental health care setting. So it depends on who you are and who the patient is and your current setting, what you can see about the patient. Then the problem of terminology that you have mentioned. You may use NOMED, you may use LOINC, you may use whatever you want, but you have to have all the terminology in one server, and all your participants in healthcare needs to see this terminology and use it and translate maybe and validate. So whatever terminology you use, you have to have some server serving this terminology. And the same happens with validation. How do you know that what you are exchanging is fine? And how do you know that it is okay for your needs, for for Indonesia. And how do you know that this specific lab result that one of the hospitals is sending is okay according to what you have defined as a consensus? You need something that validates the extensions you created and the constraints you defined. And that's another server or service inside of infrastructure. And finally, how to transport. Are you using just REST services, or are you using FTP or whatever transport you define? And finally, you need to record everything that happened. You need to record who accessed which record and who created each record. So you need audit log and trail and provenance. But this is the first time in history that we from HL7 can say that everything here can be done with one standard, mostly. Maybe not images, but all of the other stuff that we need in healthcare, the bottom part of this graph, can be implemented using some kind of FHIR resources or some spec that is inside of the FHIR family. Once you have all that in place, you may want to do what you really want to do, which is the upper half. So you can do public health reporting, you can do clinical decision support or measures like Carl showed you. You can do document exchange. You can do, for instance, knowing which allergies the patient has and which procedures or which lab the patient has. That's called granular clinical information. You can do referrals and continuity of care. You can do diagnostic orders and reporting, like labs or radiology. You can follow all the workflow in pharmacy, from prescription to supply to administration of the medication, and also adverse events. And finally, you can compile an immunization card for a patient and also get decision support on which is the next immunization to give to a patient. So for each of these boxes, you see there is something in FHIR defining how to do it. It's abstract because it's a general description, a global description. So you will need to discuss locally how you will do it in FHIR in Indonesia. That's the work that you are to do in the future. The future of FHIR is you with FHIR in the future. What are you going to do? This is what you are going to do. And this is an example. This is the number of base profiles created in each country. This was compiled by the people from HL7 Taiwan, and from the registries of implementation guides that we have access to. So there are other countries that are not published in the general registry, like ourselves in Argentina. We have our own registry for the implementation guides, but mostly you see that a lot of countries all over the world are creating their base profiles. Base profiles means the bottom half of the previous diagram, the general definitions for your country. Then you will go into domain-specific definitions. You will handle prenatal care, or you will handle cardiology or oncology or immunizations or COVID or whatever. But the bottom half is the same, and the terminology will be defined at the local level for everything. And then you will add new domains and new workflows and new use cases to your ecosystem. And where can be FHIR used? The first option is classic in institution interoperability. I mean it's classic because it's what we have been doing for the last 25 years globally. The main interoperability use is to exchange lab results and to exchange admission information from a hospital to a billing center or administrative healthcare system. So this is the way that we did interoperability in the past, and it will be eventually replaced by doing it with FHIR. The same for backend e-business systems like financial, regional health information organizations, national EHR systems, mobile applications, and public health. Those are only options, and you can select what you are focusing on depending on your needs. FHIR is a toolbox. The FHIR core spec is what you are learning in our course, but there's also each implementation guide, depending on your country and domain, the way that you specifically use FHIR for your needs. And then 3 more specs, which are handy if you need these kind of things. One is Smart on FHIR, where it lets you integrate with with an EHR and ask for information and integrate securely inside of the EHR. And CDS hooks is to provide clinical decision support in specific moments of the clinical workflow. Like when you are prescribing a medication to a patient, maybe there is a service that will tell you which other medication is cheaper or it's in stock or it's safer for the patient. So that kind of exchange between a knowledge system and an EHR can be implemented using this sister standard of FHIR called CDS hooks. And finally, FHIR is good if you are exchanging records about 1 or 2 patients, very small quantity of records. I mean, like hundreds of records or something like that about the patient, or maybe some hundreds. But if you want to exchange 1 million records or 600,000 records about the population, then what you do? Because FHIR is for immediate exchange. So there's another standard called bulk FHIR or flat FHIR, where you can ask for millions of records for public health, and the server will take a while and it will let you know when it's finished. And when it's finished, it will tell you, okay, your information is here, you can download it. And the good thing is that the format of the information and the name of the fields, like the person at the beginning explained us, that you don't want, and every time you do a new exchange for a new public health program or for the World Health Organization or for your own needs, you don't want new APIs and new ways of describing the data. It's always the same, no matter in which part of the FHIR family you are, the names of the resources are the same and the name of the elements in the resources are the same. Am I good in time? This is my last slide, I think.
Just a little bit over, actually, but please.
I will go faster. So these are the ways that you can integrate FHIR with your apps, a standalone FHIR server. And I think that the people in the ministry have discussed already the options they have. They can use any big company standalone FHIR server, or you can put a FHIR server in front of your existing application, SQL or API, your own proprietary API can be translated into FHIR, and you can have an interface engine that speaks FHIR, or you can use as an end user a tablet mobile phone application that speaks FHIR to these servers, or a web portal that combines all this information from other systems or its own storage or own data model. And finally, you can do Smart on FHIR, CDS hooks, or FHIR build data. And from next year, you will be able also to use subscription. So you may tell this a server, a FHIR server, let me know whenever a new patient with COVID arrives. So you can do something about it. Whatever you will do, it's on your side that you can subscribe to new information arriving. And the good thing is that the format that this subscription will have is also a FHIR resource format. About the course, I think you have already mentioned this. We were honored to have 20 of your participants in our last edition, and we will gladly have another cohort for the October edition. And we look forward to collaborate with you in any way we can. And that's it. Sorry if I'm over time.
Thank you, Diego. No problem. Thank you so much. We're so excited for the next round of FHIR Fundamentals course. We will be, if we have time, we will have a Q&A session at the end. So any questions that you have, can you just drop it off at the chat box? That's okay. So thank you so much, Diego, for speaking on behalf of HL7, for joining us today. It's wonderful to know the success HL7 has had with implementing FHIR and we hope to join them soon. Unfortunately, Madberg from ONA Systems had to leave the webinar early, but now we have discussed on what is FHIR and the benefits of FHIR. And so next up, we have Dr. Anuraj Shankar from the University of Oxford Center for Tropical Medicine and Global Health, and Senior Research Lead for Community Health with the Oxford University Clinical Research Unit, here to speak more on the need for team-based healthcare and what that means. Dr. Anu, please, the floor is yours.
Yeah, thank you so much. Yeah, and really it's a pleasure to follow so many outstanding talks from our colleagues. And I don't have any slides really specifically to share, but I just wanted to make a few comments. You know, a lot of the discussion around the interoperability standards and what FHIR enables, I think that's been covered. It's very important. And I wanted to highlight really what that means, you know, for quality and coverage, you know, and continuity of care for persons at the grassroots level, whether it's a child that you're trying to prevent the stunting for, or prevent or promote early childhood development, or a mom in antenatal care to identify a problem and, you know, help her to overcome that in pregnancy, or whether someone has COVID, you know, and you're trying to make sure everyone gets vaccinated, or tracking cases. So really, these are the face, you know, the face of the beneficiaries of this data interoperability. And I think what Elia presented in the beginning related to the team-based healthcare, this is really, you know, a revolution in healthcare, probably the biggest reform in primary healthcare since the development of primary healthcare and the launching of that at Alma Ata, you know, many years ago. And so the idea that, you know, multiple frontline health workers can work together as a team, providing this continuity of care, this is really enabled by a system of interoperability like the FHIR system. And so to me, that is really amazing, just so exciting to be able to see, you know, the care plan that's developed for a pregnant woman, for a child, you know, for a community to prevent or address COVID-19, being able to see that care plan or that action plan being able to be coordinated and implemented through an interoperable health information system, and seeing the gains that can be achieved by that were, you know, otherwise not previously achievable. So to me, that's really the exciting thing about this. And so I just wanted to highlight that, you know, yes, you know, certainly the data interoperability is important, but then of course, you know, what that really enables to happen in a country, I think is really exciting. And, you know, I just wanted to mention some of the exciting work that really ONA Systems is doing. So ONA Systems, some of you may know about them. They're, you know, selected several years ago as one of the top 50 genius companies in the world. And they're really doing some outstanding work on creating apps in the FHIR standard and enabling really a simplification of app development and creating interoperability. They're really part of a global FHIR working group, and I know they've been a longstanding collaborator with you all at the Summit Institute for Development. And so I think that's a very exciting group also that you all are continuing to work with. I know they've spent a lot of time working with the World Health Organization as well. You know, maybe another time, great to hear from ONA as well and the work that they're doing there. So that's what I wanted to say. And I think it's just so exciting that SID's hosted this, and it's great to see this really amazing enthusiasm. And, you know, I would thank you, HL7, I mean, all the work that you've done in supporting the FHIR work here, and you know, continuing to go forward on this, and looking forward to the work together with the MOH and Ministry of Planning on all that. interoperability, seeing these actions go forward for FHIR implementation in Indonesia. So thanks, that's all I wanted to say. Really appreciate being here today, and yeah, onward. Thank you so much.
Thank you very much, Dr. Anu. And yes, we all agree with what Dr. Anu has said. It's so exciting to be here, and it's so lovely to have all of you here. And Dr. Anu is actually our last speaker for today. And now we're moving on to a panel discussion with FHIR Fundamentals course alumni. To introduce our partners, I'd like to welcome Ms. Yuni Dwi Setiawati as the moderator for this discussion. Ms. Yuni, if you would take it over.
Okay, thank you for the introduction, Tari. And nice to meet you all in this webinar. We are very excited to have this move on. So here we have Mr. Tafri Devrian, an IT senior advisor, and we also have Dr. Ali Lamuri, a health professional and researcher, and Mr. Saldi Yusuf as a digital transformation office. And also, actually, there's a Fabeni Rio also here as a lecturer. Then Mr. Farizan Ramadan, an IT company in Indonesia, and myself actually as a FHIR Fundamentals course alumni. Elia, our first presenter, is in fact an alumna too. Okay, first I will acknowledge the great support from the HL7 in this case, also from all partners to support SID for making the course happen and facilitating selected candidates from Indonesia to be part of the course. So we as alumni, are really excited to keep this up. All right, so myself is a non-developer. So I joined the course back in August 2021, and I learned a lot from the course, and I dedicate the time and so to get through the materials. And the most important one is how to implement the FHIR course or the materials in the field. So in this case, I'm leading a science department in SID, and also we are working closely with the district partners in the local and also in national level. We promote the team-based care, in this case, the consisting of a bidan, nutritionist, and vaccinator, cadres, and early childhood development workers who they are jointly work to have a full service for the mothers, as said by Dr. Anuraj previously, and also emphasized by our all speakers that actually this team-based care can be supported if the system is interoperable. So I would like to invite Dr. Ali here. So Dr. Ali, from your perspective, why is the FHIR fundamental course really important and how it supports your work a lot?
Hello, Mbak Yuni, and good morning to all participants. So my name is Saldi Lamuri, and I'd like to address the question asked by Mbak Yuni, why FHIR introduction course is important. So in FHIR fundamental course, we had an opportunity to understand what FHIR is and how FHIR can help researchers, physicians, and all related occupation in healthcare to better manage the data. So I think it's quite important to notice that in FHIR, we could have a standardized namings for each variables. So, and it's one thing to note as well that FHIR is not something like an application or a software. It's more like a data model. How we can model the health data. I think that will be for me, Mbak Yuni. Thank you.
All right, that's great emphasis from Dr. Ali that this is a data model that needs to be make the efficient of the worker who use that standardized model. So, okay, that's really great. And we have also Mr. Tafri here. Might be in what ways, Mr. Tafri, that the course on FHIR can support your work and the experience that you have long way back in your professional development.
Okay, good night, everyone. Good afternoon, good morning, because it's now is a time difference. So, and then terima kasih juga sebesar-besarnya untuk Pak Setiaji dan Pak Agus yang hadir. Okay, about the course, but actually I'm developer, but retired already. So when I got the course, time for me to learn, to adopt or something like that. But overall, the course is very, very excited. The material is good, and apa namanya, the learning process is interactive. The tutor is very responsive, and it's good. The material is good. About to support my professional job, actually, I'm not really in the development side, but I'm only it's like this. I'm a consultant now, so can be a suggestion or something like that. And then the last one is better SID and the team from FHIR International or WHO to make a workshop, but workshop for FHIR non-developer. As like mentioned before, lot of confusion, bingung about the FHIR itself. And then the last one, for the developer thing, it's better to make or add some or use the Indonesian case study for the developer FHIR training. I think that's it from me. Thank you very much.
Okay, thank you, Pak Tafri. Yeah, really great emphasize also from Mr. Tafri that the FHIR course is not only for developers, but also really important to be attended also by non-developers. And I think this one that we collaborate with the HL7, so the Summit Institute for Development is now collaborate with HL7 to provide and to facilitate more Indonesians to join in the course. All right, we also have here Mr. Farizan from the company, IT company here in Indonesia. And Mr. Farizan, actually, what kind of lesson learned that you got from the course and how this knowledge can be transformed into action?
Okay, thank you for the opportunity. First of all, my name is Farizan. I'm still active on developing software as analyst and advisor. And my impression about the FHIR, first of all, FHIR is easy to be used and implemented because the structure and then the concept is IT developer friendly, in my opinion. And then the most important about the technology stack is the well-documented. FHIR is well-documented. The FHIR have official site or wiki, and then have a clear instruction for the components and elements, and then the clear suggestion to implement all of the module or the features. And then also FHIR have a flexible and standard for multi-approach technology programming language, and then the technology solution. It's also scalable. And then the most important about the flexible and standardization is the multi-purpose. We can implement FHIR in small into a big scale of software development. So at the conclusion, my impression about FHIR is one, a good starting point to develop, and then a great standardized format, and also a recommended interoperability solution. Maybe that's all from me. Thank you.
All right, well, great talks from Mr. Farizan to say more that actually FHIR is kind of really easy to get it scalable, but also it can work in small scale. It is also, I think, it really fits with Indonesian context now that we have a diverse population with a diverse system, yeah, from the health, education, and so forth. So it will support the country a lot. So also here in the countryside, the country, we have Mr. Saldi here. So Mr. Saldi is from the Digital Health Transformation Office. And I would like to know more about how's the course lead you to move to the next step in this case, and how it will be accelerated to get the FHIR implemented, let's say, in Indonesia.
Right, thank you so much, Bu Yuni. Izin Pak Chief dan Pak Agus. Jadi so before get over to DPO, lucky me, I can get more technical skills with the course supported by SID in HL7. So thanks for the opportunity. And actually, initially, I get exposed technically with FHIR when I was in my standard and interoperability class in my master study. And finally, in my final capstone, I also work with FHIR, but it's really, it was more like system analysis and evaluation point of view of FHIR. It's really about extension point of view of FHIR. But during the course in general, I became more skillful and I became more familiar working with FHIR. It's really interesting that we have another batch for FHIR course in the next month, because we definitely need more and more FHIR talents in Indonesia, obviously. But of course, myself really become more curious about FHIR, especially for architectural configuration and core specs, and Diego said CDS hooks, smart on FHIR, etc. And it's really interesting, and I'm excited for the next step of this project. I think that's all, Bu Yuni.
Yeah. Okay, thank you. That's a very great from Mr. Saldi, that the needs of involvement from developers and also non-developers from Indonesia. Let's get them 1,000, maybe 2,000 of Indonesians to be the FHIR alumni. That will be great. So actually, we also have, I think Pak Benirio is still here. Pak Benirio, maybe you want to summarize from this discussion about FHIR, the alumni.
Thank you, Ms. Rini. I would like to say thanks a lot to Anuraj and SID to offer me to involve the course, I think. Actually, I am already familiar with the FHIR before Mr. Anuraj offered me to join the course, I think. So I'm a selector. I will like to introduce this standard, this good standard, to my students as those, if they are going to develop a system, especially system for the around the health information system, something like that. So I think this course material and also FHIR standard is very, very useful for us and also for our student. And then I use this FHIR standard as a course material in my cluster. Thank you, Ms. Rini. Thank you.
Okay, great, Pak Benirio. So it's already transformed. I mean, it's already get transferred into the students for getting the standardized data. Well, that's really great, to have the next generation of Indonesia really familiar and take action into this data interoperability. Yeah, I think it's very important to have this all discussion that we will keep going to roll out the course in fundamentals, course on FHIR, and Summit Institute for Development will be happy to facilitate that in collaboration with HL7. We will announce it publicly for the recipient of the scholarship by next month. So cannot wait to see that to more Indonesians involved in the FHIR fundamental course. That's really great opportunity for developers and non-developers to take a part in making real of one data system in Indonesia. Yeah, I think that's from our side. So get it back to Tari. Thank you.
Thank you so much, Ibu Yuni, and also to our panelists. We have Bapak Tafri, Bapak Saldi, Pak Farizan, Pak Ali, and of course, Pak Beni. Listening to your raving reviews for the FHIR Fundamentals course makes me really excited, as I'm sure we all are as well, to take the course. I hope to see you all in our next round of FHIR courses. So now, since we are done with the panel and we have a little bit of time left, We can now move to our questions. Let's see, what do we have? We have a question from Andio. He asked, where does FHIR envision itself on the future of EMR for patients in Indonesia? That question is going towards Ibu Inti, is that correct, Pak Andio? Or if anyone wants to go ahead and answer, that would be great. Or if
you want me to address that?
Yes, please, Diego. Thank you.
Diego. I think it's the other way around. It's how do you envision your EHRs on FHIR? What is that you want to happen? And how you will use FHIR to make it happen? FHIR is your tool to do what you need. So it will work any way you want. It has its limitations, but you need to define what you want from a perspective of what we saw at the beginning, patient care. What happens with the people taking care of the patients? What information they need? How can we make that happen? Where is the information? How can we open the silos using FHIR? That's your question for the near future, I think.
That's a lovely answer. Thank you, Diego. Pak Andio, does that answer your question, or would you like to ask for anything else? If not, maybe we could move on to the next question. There you go, Dr. Anu. Is there anything you'd like to ask?
I had a question. For our colleagues from the Digital Transformation Office and from Bapenas, is that how are you envisioning, kind of the rollout of this interoperability? Are you thinking about it like it could be something done at district level and at central level simultaneously, or something coming mostly from central level and later district level, or how are you thinking about this and from just sort of a general strategic approach? Maybe Pak Setiaji initially, and maybe after that, maybe Ibu Inti and Pak Suparlan, whatever your thoughts are.
Pak Setiaji, apa masih hadir? Pak Suparlan mungkin? Atau Ibu Inti? Monggo, silakan.
Ya, makasih Bu Amil. Thank you Pak Anuraj. Maybe because Bu Inti, I'm not sure because Bu Inti is on the way, so I'm not sure if she can hear clearly. So I think the question is very hard, Pak Anuraj. Yeah, you talk about how our ambition from the government side to use this what is called FHIR, because interoperability data is it's very challenging from the beginning, even in Indonesia, how to create the data that, as we have also discussed, I think in the beginning of this webinar, that we have a lot of system, even we need to improve that on one side, but I think how to make the system to be integrated, even in the central or in the national level, we are still, in the ongoing process of that. And your question is how it will be integrated also to improve that until district level. It will be more challenging, I think. But of course, there are a lot of effort to that, and Ministry of Health, I think they also start to combine, like for instance, that have presented by Bu Inti. If you talk about the stunting, because now we also develop some like database, governments have developed also the database from health, but I know this database we also need to improve. So it will be very interesting if we can like, I mean, initiative like FHIR or whatever that from CSO or even from the other NGO that we can learn and join and collaborate together. I think the government is very open. Even in one side, we know that there is like a mechanism of the bureaucracy, but from the government side, I think we really want to collaborate, especially for the initiative or the good model that we can develop, and we can make a good system that data will help the service, will help the health prevention, as you mentioned before, like how it's not only to create or to improve the service, but also how we can also ensure that security of the data, privacy, etc., as part of the system. I think that's that I can answer. I hope can be answer some of your questions, Pak Anuraj. Thank you.
Yeah, thanks so much, Pak Suparlan. Very helpful.
Thank you so much, Pak Parlan. Mungkin Pak Agus mungkin bisa menambahkan sedikit?
Mbak Tari.
Ya.
Iya. Saya Dian dari Bappenas.
Oh, halo ya. Gimana Bu Dian?
Maybe if I may add something from Parlan's explanation.
Yes, please go ahead.
Okay, thank you. So as what Bu Inti have explained before, currently Bappenas is developing an integrated monitoring system. As it is our job as Bappenas to monitoring and evaluating all what happened with stunting reduction in Indonesia, we try to integrate the monitoring and evaluation system from the input process until we can see how is the impact of the program to stunting reduction. Currently, the process is still at the national level between ministries, but after that, we try to, we try to integrate the system at the sub-national level. Maybe that's what I can add. Thank you.
Okay, thank you so much, Ibu Dian, for that quick extra insight. I am afraid we've run out of time. So I'd just like to thank everyone that has joined us today, to all of the speakers. Thank you so much to our partners and all of you that has been here today. We truly appreciate it. And we hope that we all now have a better understanding on FHIR. And on behalf of SID, I'd like to thank you for being here. And we hope that this can be our first step in the implementation and adaptation of FHIR in Indonesia. If you have any other questions, please send an email to secretariat@sid-indonesia.org, which you can see in the chat box. There, if you have any extra questions, and we'll get back to you as soon as possible. I'm sure we are all so excited to take the FHIR course. We're going to see what's going to happen next. So on behalf of SID, I'd like to thank you, and I hope to see you at our next webinar. Thank you so much, everyone. Good night.
Thank you.
Thanks.
Thank you.
Terima
Good night.
kasih.
Thank you, everyone.
Terima kasih Pak Suparlan dan Ibu Dian, serta Ibu Nur Dayati dari Lombok Timur.
Thank you. Terima kasih semuanya.
Thanks all. It's fantastic. Thank you.
Terima
Thank
kasih,
you.
Ibu.
Terima kasih.
Terima kasih
Thank
Dokter
you.
Ali, Pak Beni, Rio.
Thank you.
Terima kasih
Bye.
Pak Suparlan. Ya, terima kasih Pak Roy.
Terima
yang
kasih Pak
sudah
Roy,
hadir.
Dokter Ina.
Dr. Rina. Thank you, Dr. Beth.
Terima
Ya.
kasih Pak Rando.
Provisiat.
Hey, Roy, how are you? Yeah.
Thanks all
Bye.
SID staff.
Terima kasih Pak Tafri. Thank you so much.
Sama-sama.
Terima kasih
Terima
Pak
kasih Pak
Tafri.
Tafri.
Thank you. Bye-bye now.
Bye-bye. Thank you.
Terima
Rini.
kasih
Bu
Dr. Rina.
Nur Hidayah.
Terima kasih Bu Nur Hidayati.
Semangka.
Yeah, thank you.